Great. So Ina, can you give us that perspective about healthcare reform?
Yes, thanks, Kathy. Good morning, everyone. I hope everyone can hear me. I'm sitting a little bit away. All right, great. And Dr. Soroyan and I wanted to be in the same room together because we have so much to talk about and we can exchange ideas here together in the same place. Healthcare reform, I think it is a very broad and encompassing topic, and it is not necessarily specific to one particular initiative or reform model. When I try to ground myself in healthcare reform, I think it's helpful to think about key examples of healthcare reform work in history, and one of those that's in fairly recent history is the Affordable Care Act. And I think when a lot of people think about healthcare reform, they think about the Affordable Care Act. And within that act, so many things were contained within it. Insurance marketplace reform, prescription drug reform. At one time, there was in the Affordable Care Act effort to establish long-term care insurance, a public long-term care insurance program for people. Just a sweeping package of different ways and different proposals and initiatives to better support persons throughout the whole healthcare system and in different ways of interacting with the healthcare system. So whether it was expanding Medicaid coverage or providing subsidies for persons purchasing commercial insurance or establishing essential health benefits, a benchmark of concrete benefits that people who are purchasing insurance in the marketplace should be able to avail themselves of. That's all a part of certainly work that was launched with the Affordable Care Act, work that we continue to engage in today in the healthcare reform space in Vermont. And that is all healthcare reform. Some colleagues of mine always say, what problem are you trying to solve in healthcare? Are you trying to get more people access to the system via coverage, making sure that people have coverage so that they can access the system? Are you trying to ensure parity of coverage for mental health services and physical health care services? There's been a lot of work in that space in the state of Vermont prior to the Affordable Care Act, and then the Affordable Care Act really enshrining some of the work that Vermont did for the nation. That's another part of healthcare reform. And then the Affordable Care Act also created the Center for Medicare and Medicaid Innovation, which was really grounded in working with states to develop models to pay differently for healthcare, reimburse differently for healthcare, and then through those changed reimbursement models, delivering services differently. And we have a lot of experience in that space in Vermont, both now, today, and prior to the Affordable Care Act. Some of what the Affordable Care Act was supporting, such as patient-centered medical homes, for example, through these changed payment and delivery models, Vermont had a history and was working on that prior. I think the question we should ask ourselves when we're working in any realm of the healthcare reform space, whether it be looking at the essential health benefits or thinking about ways to reimburse differently for services, is whether or not those approaches are supporting whole person integrated care. And one of the examples recently, or more recently, that might be interesting to talk through is the recent change in what the essential health benefits and the benchmark plan for coverage in the state of Vermont looks like when a small group or an individual are purchasing insurance in Vermont. What is the benchmark plan of coverage? And one of the things that that we thought through, along with the Department of Financial Regulation and the Green Mountain Care Board and the Department of Vermont Health Access, And a lot of what my role encompasses is coordinating among these departments and agencies and the Green Mountain Care Board was what makes sense in terms of the benchmark plan for essential health benefits for people to receive. And hearing aids was one of those items that was looked at closely, recommended, and is now included in the benchmark plan. And I think that's a really interesting example because hearing aids really do support whole person care and better health and well-being in all avenues of life. So being able to hear means you may feel less isolated. Being able to hear may also mean that your balance is improved and you are less likely to fall or be at risk. So I think that's a great example about how we can be looking through that lens to support whole person integrated care, no matter kind of the healthcare reform realm that we're working in. And we can certainly talk more about payment and delivery reform. And I'm interested to talk some about whether you have to do payment reform to do delivery system transformation or not. And certainly the way that those pieces also shape and can provide for more integrated whole person care.
Great, good. That was very helpful. Thank you, Ina. So Dr. Saroyan, let's go to you. If you could tell us a bit about the Blueprint for Health and how you imagine healthcare reform will affect care. The kind of changes you're anticipating.
Sure. Kathy, I'm not sure people know who I am as well as they know who Ina is. Is it okay if I just say a few words about myself?
Oh, please do. Yes.
Because while I've been on the pediatric subcommittee, I don't know as if I've introduced myself to the group. Good morning, everyone. It's nice to see some of you and nice to look at the list of distinguished participants in this group. And Kathy, thank you for the introduction and organizing us all so beautifully. Ina and I are here in Waterbury today. I feel a little bit like we should have a mug of coffee on both sides of our camera and doing like a New York City kind of morning show or something like that. But anyways, I'm John Saroyan. I live in Norwich, Vermont. I moved to Vermont in 2013 to become the hospice medical director in New Hampshire and Vermont for Beata Home Healthcare, and transitioned to this role on January 3rd. And I'm thrilled to be taking my knowledge of the many different communities of Vermont to a role that can really put that to work. Speaking of hearing aids, my wife and my son both need hearing aids because there's a genetic component in some sensory neural hearing loss. So the hearing aid benefit hits my home in a very a big way, but it hits all of us because whether it's our colleagues or our families, hearing loss is so common amongst people that we can communicate better, even if we're not the ones receiving them. And they're very, very expensive technologies. So just to bring it home to that. Kathy, I think that my answer to your question is sometimes a little unexpected because of the Blueprint's history and its leadership in the past and the legislature and the executive branch and also as the executive directors and their wonderful staffs have been, because Blueprint for Health has both been an instrument of healthcare reform and been an influencer of healthcare reform nationally. There are parts of the language in the Affordable Care Act that do mention patient-centered medical homes, and I'm pretty sure, though I can't reference it myself off the top of my head, do mention community health teams. So I think it's easy to get for me and others, it's easy to get confused about who's affecting whom. And it's exciting for me to work down the hallway from Ina and others who are still trying to influence the direction of the national leadership's approach to healthcare based on our experience in the Blueprint. So I'll get to your question now. That was just all background, Kathy. The Blueprint for Health has several components programmatically. One is the patient-centered medical home. This is written into statute in Vermont that to be a medical home in Vermont and to be what's called a blueprint practice, a practice needs to meet the standards of becoming a patient-centered medical homes. That's a model of care that focuses on patients at the forefront and building better relationships between patients and their clinical teams. Research generally about patient-centered medical homes, but also multiple studies about Blueprint for Health in Vermont have looked at its improvement in quality, patient experience, also staff satisfaction, while reducing healthcare costs. So just the patient-centered medical home alone is a way to look at healthcare delivery and affect costs. I think that Vermont is the envy of many places, especially, for example, when we meet with New York State's Office of Medicaid, because they have the patient-centered medical home aspect of it. They don't have the community health team aspect of it. And the community health team is in concert with the patient-centered medical home as a multidisciplinary team that takes that focus on the person, the family, the individual, and provides, particularly in the beginning, but even now, the types of services that are not reimbursed at all, perhaps are not reimbursed well, perhaps come at a high copay, and provide a more and possibly a complete equal distribution of those services. For example, care coordination, nutritional services, access to self-management, perhaps a community health worker, many other ways that our different leaders around the state utilize dollars for community health teams. And community health teams, in concert with the patient-centered medical homes, in the pilot studies that were part of the blueprint, in addition to evaluations in the late 2000 teens, continued to look at those being able to bend the cost curve and also keep people out of inpatient stays and ED utilization. So those are two of the programs that really were the core of the blueprint since then. And because of the Affordable Care Act, the Hub and Spokes program, also very much a national leader in Vermont, the envy of many other states for the treatment of opioid use disorder. And while I think we have the position and a responsibility now in 2022 to look at how that program can maybe modeled in other ways around mental health and non-opioid substance use disorders, the fact that Vermont has a hub and spokes program that was built really over 3 years because of an opportunity for not just matching funding, but what's called 90-10 funding from the federal government for quite a while. Vermont took advantage of that, and we need to do more. But again, those types of systems are what put us at the forefront still. At the same time that all of you know, we have problems both in mental, physical health and substance use disorder that are off the charts right now, that need more investment, that need more invention and innovation to address better. Kathy, I'll pause there. I haven't mentioned all the programs of Blueprint, for example, Women's Health Initiative, but I think that's a strong overview, at least to get us started this morning.
Great, thank you, Dr. Saroyan. That's very helpful. I thought maybe next we could move to Dr. Levine. We've been more focused on sort of practice level questions, but VDH, of course, works on the population level. And so I'm wondering, Dr. Levine, if you can kind of reflect on where you think healthcare reform is going to affect the public health world. And if there are examples that come to mind, is that too broad a question, or does that work?
Oh, that works just fine. Okay. Good morning, everyone. I'm going to begin what I have to say with the so-called triple aim, because that kind of integrates everything together. Many in this audience will actually recognize the term. Others will be like, what's he talking about? So the triple aim is a pretty simple concept. It basically looks at healthcare reform in a very global manner and says, Part of what's going on now that needs to be corrected, it's been going on forever, is we pay way too much for the health care that we get. So costs. The other part, as Ina was using in the terms delivery system reform, is we don't always get the biggest bang for our buck. So that really looks at issues of quality of care, performance management. I'll use the word customer in quotes, customer satisfaction or patient satisfaction. And then the third part of the triple aim is actually the word health. So is what we're doing actually creating a healthier individual and a healthier population? Now, we are in very troubled times post-pandemic, so it's probably appropriate to say that many have extended the triple aim to the quadruple aim. And the fourth part of the quadruple aim has to do with the health of the workforce and where everybody's at. So not only are we trying to help people, as we always do in healthcare, to attain the highest level of health, but our workforce has to be a consideration as well. So when I look at healthcare reform, it's very obvious, I think, to most people at this meeting that cost is always the thing that gets focused on the most and remains a constant focus. But that delivery system reform has indeed been a significant component. And programs like the Blueprint are the tip of the iceberg here, but so much has happened with the way healthcare is delivered and the focus on quality and patient safety specifically. The forgotten stepchild generally is that health part of the triple aim. And thank goodness the Affordable Care Act did occur, because it did begin to elevate that to some degree. Although when you're trying to really overhaul a healthcare system, those other two factors really drive the ship, if you will. And the issue of access always has been a significant driver. So as a public health leader in the state, and as the department that really focuses on the whole population, we are very much significantly looking at access all the time. And when you think about the kinds of principles that we want to have for our healthcare, access and affordability are certainly two of the highest, along with, of course, equity. So the Affordable Care Act was hit with a significant blow with the Supreme Court a number of years ago, as you'll recall, on the issue of Medicaid expansion to everyone. And we do have still a core number of states in the country that have not benefited from the kind of Medicaid expansion that we in the Northeast are very familiar with. And that's important because generally these are the states that need it the most. And they need it the most mostly for issues of health equity. And to be frank, quite often racial equity. So that is a serious problem in our country right now, because not every state is in the same kind of reform stance, because they have that opportunity to opt out of full expansion. Having said that, when you're looking at population health, concepts like what is the return on investment going to be if something gets invested in? Is there more value as we transition from so-called fee-for-service systems to value-based care in what the population's getting? So if you just look at the problem of, let's say, tobacco use, tobacco and vaping, clearly just a minor investment like in state quit lines and access to the quit lines, and allowing the population who can afford it the least, the Medicaid population, to have free access to smoking cessation counseling and aids. that can increase the sustainability of someone's smoking cessation related efforts substantially for a fairly small investment, to be quite honest. And we all know that tobacco leads to such significant rates of disease in our population that costs gazillions of dollars. So just thinking with that kind of a mindset not only enhances the care that an individual will get um, just because they happen to smoke, but it will also do something much larger at the population level and then impact those other aspects of the triple aim triangle. Because you've reformed the delivery system to some extent with this action, and your costs overall in the future are going to go down significantly when you consider that 80% of most of our healthcare costs go to chronic disease, and think of the chronic diseases that tobacco use is leading towards. I also wanted to pivot off of what Ina was saying about those essential health benefits, because those are so important. And within those health benefits, of course, are the opportunity to get screening tests at no cost and to have significant conditions screened for. So this is the part of healthcare reform that really focuses on prevention, which is where all health departments are focused all the time, laser focused 100% of the time. The other place where we are focused and that drives our state health improvement plan, which is a 5-year plan we keep reiterating over years and years to really get the state focused on what counts. The two components now are called the upstream components. One is health equity, and the other is addressing the social determinants of health. And through the development of the Innovation Center that Ina was referring to, CMMI, we're making some small steps in that direction as a country. And of course, states like Vermont are always interested in leading and trying to get there faster, but these are very heavy lifts, needless to say, especially when you think about the impact of housing and food security and parity across education, no matter what population you live in. Those are very heavy lifts for any state or country to achieve, but that's how you achieve better healthcare. So as we make progress in that arena, obviously our work as a health department will be easier, but at the same time, we will find that healthcare reform has driven the kinds of upstream improvements in our systems that need to happen to enable people to be healthier in general. I've purposefully avoided specific focus on mental health and substance use disorder in these comments. I wanted to keep them fairly general, but just so you'll know, there are 5 priority areas in our state health improvement plan. 3 of them include prevention of chronic diseases, improvements in oral health, and child development. But the other 2 are the 2 that we're addressing in this council every time we meet, which are mental health and substance use disorder. So they are very part and parcel and core to the entire mission of healthcare reform. And when we start thinking about what are these essential health benefits that everyone should have, and what has the blueprint done already to provide some element of access to those kinds of benefits in mental health and substance use disorder, we've made a lot of progress in our state. And the work that we're doing in this council can only get us further. So I'll stop there, Kathy, so we can really keep our focus going as we have with our guests. But I think, thanks, I appreciate your allowing me to provide that context.
Yeah, great. Thank you, Dr. Levine. It was very helpful. And then I wanted to shift to Allison. We've talked about certified community behavioral health clinics in within this council, and we have one CCBHC, they're called, by in short terms. And there's news about other grants. So it seemed like we should talk about the certified community behavioral health clinic model, how healthcare reform might affect that. And maybe you could give us sort of the context of the grants and what's happening in Vermont right now.
Sure. One of my favorite things about CCBHCs is trying to watch people say the term CCBHCs. It's a tricky one. We do have Clara Martin Center, who has been on this journey. They started first. And so then we have additional planning grants that were awarded. So if you're not aware, we've got HCRS, that's Healthcare Rehabilitation Services of Southern Vermont. We've got the Northeast Kingdom Human Services, who received a planning grant, and Rutland Regional also received a planning grant. And then Clara Martin Center, their grant is to continue with their planning, so it's a little bit different than the others. And so for people wondering what this means, and I think in the context of what Dr. Saroyan and Ina and Dr. Levine have been talking about, we wouldn't have a CCBHC opportunity if there wasn't such a thing as healthcare reform. The whole thing is looking at how do we do different service delivery models and payment models. I think what makes this conversation interesting from DMH's lens is we've actually started payment reform already. And so some of this stuff, when we think about, why move in this direction of CCBHCs, I think to Ina's question of, do we have to do certain payment reforms to do certain service delivery models? And so one thing the state is really interested in is making sure, can we do a lot of the things people want to do without going through certain prescribed additional regulation and compliance? And what does that actually get us? So right now, what that actually gets us is more money, which is really attractive in the world that we're living in right now. And so we've seen our community mental health agencies being interested in this for a few reasons. One, it fits the mission, right, which is to start moving towards more integrated care. CCBHCs are really focused on having the opportunity for somebody who walks in that door to get more medical screening, more physical health consultation, to get more substance use screening and more substance use treatment. That's intentionally broadening what is looked at for that human being. And then it talks about maybe some lines of focus, like, for example, they really want people looking at veteran status and military connections so that they can make sure we're connecting folks to those services. So it's kind of naming that. It's naming peers as a major part of the puzzle, which has been a focus of this council. And then it's talking about mobile crisis response, which has been something that we have heard from families year over year over year, that what they want is to receive the services where they're at. And this program requires that there's 24/7 mobile crisis response. And it requires that that response has the ability to have a peer component and that they can do integrated crisis response. Integrated in that definition is substance use and mental health. So those are some of the things that are really sort of, I would call, beefing up and kind of making tangible, here's the standard of what we're trying to do. And for the community mental health agencies, those aren't fitting with their values and what they've seen as needs for their populations. I think, and this is where, will be something that warrants further discussion, some of these things we could do without shifting to a new way of payment. And some of these things we're seeing as, here's some opportunity that helps us pay for the uninsured and underinsured and helps, make it easier for flow and somebody coming into the system and for the agencies to remain stable as they serve people with variable levels of insurance and need. And so I think it'll be interesting to see how this bears out. what makes CCBHCs different in the way they're paid is there's, we'll call it cost-related reimbursement. And I say that because I do want to make sure we're all clear that there's no such thing as just like a blank check. And we say, okay, here's what it costs, and we magically just deliver that number. And unfortunately, there's a certain cap on the amount of dollars that there are. But this opportunity has come with some additional here's some additional funding you can get, and here's why. And so we're all very interested to see what that can deliver, and how we figure that out and right size it to the services that are occurring. And so that's an exciting thing. There's a lot of homework to do. And so I attend, along with my DMH partners and a lot of the community mental health folks, there's a policy academy. We've been going once a month. Every time we go, you learn more about, okay, what are the actual nuts and bolts that come along with this? And I think, Kathy, did you want me to talk about unintended consequences that we're concerned about, or is that a follow-up for later?
Well, yeah, maybe you could give us some points about that, and then I was going to go back to Ina for a few more specifics about healthcare reform itself. So yeah, that could be good to hear that now.
Sure. I think when we think about this and we hear about healthcare reform in other areas, we had a great discussion about this at our workforce development subcommittee on Friday, which is part of this council. And we talked about how for those of us in the mental health world, it makes you nervous to hear about mental health services expanding in healthcare, because what you're worried about is, well, okay, great, now here I am trying to serve over here. Someone else is going to try to do something similar at an organization that's only open during business hours, and potentially might, some folks think, works with a less acute clientele. How are we going to manage this? And isn't this going to suck up my mental health workforce? And so we're talking about how to just think forward about that, because I think it's easy to say, so then everybody go back to their corners and let's not mess with anything. And I think we've said the goal of this council is to provide more integrated healthcare, which means more mental health in healthcare spaces. And so how can we be thoughtful about the realities of staffing? How can we really talk about shared staffing, about how we can maximize and do contracting with each other so that people understand what, hubs and spokes can provide, but maybe have somebody in their clinic who is contracted with a community mental health agency who can help be that bridge. How are we going to do some shared staffing with psychiatry and nursing and things that are limited resources? What can that do for making sure that everybody understands what each organization offers, and we then can refer appropriately? So that's one thing that I think we need to keep talking about, as opposed to just kind of being afraid of, because I think it's going to be easy to have that stop us in our tracks. And the only other thing I'll name is for the folks who've been in the room who represent different peer communities. I've heard them saying that, let's keep an eye on how medical model this is. There's still a lot of medical model pieces to the CCBHC and a lot of healthcare reform in terms of, great, we're not doing fee for service, but we are saying, well, let's base it on quality and performance, and how much of that quality and performance is really steeped in a medical model that doesn't feel to the person like it's reflecting back what they care about. And so we're interested in seeing what's flexible about that.
Yeah. Allison, I and not to put you on the spot, but I'm wondering, and I do this, we use the term medical model. Can you give me an idea of what you mean by that? Like, why would it matter? What do we mean in and it matters, like, your perspective? What does the medical model encompass?
Yeah, it's a great question. Thanks for stopping me on that one. When I think of my opinion on that, it's more Western than Eastern medicine. It's more diagnostic based, and it's more, I'll give you an example of something that really drew people's attention when they saw BMI as a major factor. If somebody coming in, one of the first things that we're going to do is we're going to look at your body mass index, and we're going to decide if that's okay or not okay, and we're going to set a goal for that. And for that person, they've said, maybe that's not my goal. And where do I get a say in any of that? And so that idea of a prescribed sort of hierarchical, the experts have decided what's important, and we're fitting you into something that's really prescribed, and then it's decided by someone else whether things are going well or not going well.
That's great. Thank you. That's really helpful. Okay, thank you. I found that helpful. I hope others did as well. And just really that overview of CCBHCs and the factors within our payment reform efforts that the department had embarked on in 2019, and where things might be headed with that. So we've done, we've heard a bit about an overview about healthcare reform. We've heard a bit about how the blueprint functions and intersects with healthcare reform, and then the population health interests and the certified community behavioral health clinics. So I'm wondering now, could we kind of step back a bit again and go back to Ina? And if you could, when we last talked, when we were talking about this meeting and how this would go, you mentioned 2025 as the significant point in healthcare reform. Can you tell us a bit about that? What's significant about 2025?
I can talk about 2025, but I want to start by responding to some of the things that both Allison and Dr. Levine said, and get to 2025 through those responses, because I think what Dr. Levine said about the triple aim as an impetus for payment and delivery system reform is incredibly important and is helpful for us to ground our thinking. Why are we talking about paying differently for healthcare services, and what does that mean? The predominant reimbursement system for healthcare services in the United States and in other countries too, but speaking just about the United States now, has been fee-for-service reimbursement. And the other piece about that has been the predominant component of fee-for-service reimbursement is, if you think about it as one end of a continuum, the first end of the continuum, and again, the predominant way that people are paid, is fee-for-service reimbursement with no tie to quality or value. That fee-for-service reimbursement occurs regardless of outcomes, regardless of the value of that service. And that is, if you think of it again as a continuum, that's one end of the continuum. And then if you consider that you have a goal to move away from fee-for-service because of the incentives of that payment for every procedure and service, regardless of what the outcome is or the quality of those procedures and services, which is, again, the way we primarily pay in the United States and have historically. And then consider, if you start tying payment to quality and outcomes, what that looks like. And the blueprint is actually an example of that. The blueprint moves away from fee-for-service because the model includes enhanced payments for high-performing primary care patient-centered medical homes. And the blueprint also includes more flexible payments and investments in the community health teams. And those are supporting integration of services and care, and starting to move away from what Allison mentioned about the silos of care happening in silos. So you have a model that's becoming more flexible, moving away from fee-for-service, and, for example, really promoting integrated care, with the spoke example being an excellent one of the primary care having a multidisciplinary care team that is supporting physicians in that practice and the practitioners in that setting in providing medication-assisted treatment for persons with opioid use disorders. And so the blueprint model is an alternative to fee-for-service. So it's moving away from fee-for-service with no tie to quality and outcomes to a alternative payment model that does have a tie for quality and outcomes and includes payments that flow differently than just a reimbursement for every service and procedure that is performed. Then in our work in payment reform in the state of Vermont, we have also had a goal to move even further from fee for service more towards a global payment. So instead of fee for service with an enhancement, like the Blueprint program is, really a truly global payment for healthcare services for a population of people. And that global payment is also then linked to quality, outcomes, and value for the population. And the idea behind that global payment is it provides even more flexibility because it's being provided upfront, giving the healthcare system and providers working within the global payment a budget to manage within, and a model that's more flexible than just being paid for that for any particular service, a model that can help to provide for a budget so that preventive activities can occur, coordination between and among providers can be supported, providers' time working with each other to gain experience and expertise from a multidisciplinary approach, supporting multidisciplinary teams and teams that include unlicensed providers, for example, like potentially community health workers, as a part of that overall care team working in this more flexible arrangement. That's getting all the way to the other end of the continuum. And I think my question that I was posing about, do you need to do payment change necessarily, meaning not pay fee for service in order to deliver care differently? I was posing that question because I think that there's probably a mix of reimbursement models that need to be implemented in a complementary nature, and likely the opportunity to tie these different reimbursement models together, but not every reimbursement model necessarily is uniform for all providers and provider types in the system, for example.
Ina, can I interrupt you for a second? You used the term, I just love that. That was really, really helpful to hear. And you used the term multidisciplinary a couple times. Is that another word for some level of integration when you say multidisciplinary?
Yes, I think so. That's it. That's how I think of it. Absolutely. Team members who are all coming together and collaborating and providing care for a person across a number of different needs, and including different expertise and service types, but all working together to deliver whole person integrated care. Yeah.
Great, thank you. And can you take us to 2025 also?
Yes. So what in terms, again, we've been working to ensure that, we've been working towards a goal of aligning these fee-for-service alternative payment models across payer types. And that's very important because if only Medicaid is paying differently and expecting particular outcomes, and Medicare and commercial payers are paying a different way and expecting different outcomes, then the incentives are not necessarily aligned. And the reimbursement model is not necessarily supporting that alternative delivery or that team-based care, for example. And the blueprint is a great example of, again, of a model that is aligned across payer types to an extent. Commercial payers participate. Not all commercial insurance participates, but commercial insurance does participate. Medicare participates and Medicaid participates. And Medicare participates via our all-payer model agreement that we have currently, where we're moving towards and have implemented in the Medicaid payment model, in the all-payer model, a more prospective population-based payment provided to hospitals through Medicaid that are participating in the accountable care organization. And we have the reason why 2025 is interesting is because we have proposed to extend our all-payer model agreement and are working on that extension with our federal partners. Our current agreement, which again provides for Medicare participation in paying an accountable care organization in Vermont differently than fee-for-service. That's OneCare Vermont. Commercial payers are paying OneCare differently than fee-for-service. And again, Medicaid is probably the most advanced in doing this and providing for these population-based payments. We're looking to extend that arrangement while we then work with our partners in the Innovation Center to consider how that model may advance beyond 2025. Vermont proposed a 1-year extension, and we wanted to work towards a more longer-term extension from that point forward. Our partners in the Innovation Center are really focused on how they broaden models to more states. And they said that they were looking for some more time to realize those goals and objectives. And they have offered that Vermont could extend our agreement for 2 years instead of 1, so that they can do the work that they want to do to invite more states into participating in these alternative payment models. So that's why we're looking forward to, beyond a potential extension of our agreement, how we continue to advance in moving away from fee-for-service in 25 and beyond with Medicare, potentially as a partner, but certainly in our Medicaid program, as we've been doing, and in commercial spaces as well. And I think there is an objective to continue pushing away from fee-for-service more towards global payment arrangements. And there's a lot of things to think about in that aspect. Attribution, how people are attributed to these models has been sort of central to paying differently. Who are you paying differently on behalf of, and how do you identify these people? And I think that that's a place where we have a lot of room for innovation and improvement, for example, and also to be thinking differently about health equity and addressing health-related social needs. Because when we're talking about persons coming into these models and being attributed based on how they experience the healthcare system, I think we can think a lot differently about the population on the whole and how the population on the whole may or may not access healthcare services in a way that identifies an individual for attribution. So how do we think more globally to encompass those persons in our system that may not engage in a more, certainly in the ways that have been identified to date for attribution. So,
well, I'm wondering, I don't want to go too much into the weeds, but you've mentioned the Accountable Care Organization. We know there's the UVM Health Network. We know there's the Blueprint for Health. And I'm just thinking, and then there are private practices still out there. There are the hospital systems where that are part of the Accountable Care Organization for the most part. But, for the person out there who's not steeped in healthcare reform, I'm wondering, is there a thumbnail you could give us of just here's the accountable care organization and what that means, just really briefly, just so people are like, wait a minute, we talked about the blueprint for health, and you've just mentioned the accountable care organization. Do you see what just to try to, maybe if we could just get the threads distinct, I think that might be helpful.
Yeah, absolutely. The blueprint is rooted in the primary care setting, although it certainly pushes the envelope beyond primary care and supports primary care extending into multidisciplinary teams. And that is a foundation in Vermont's healthcare system and has been working, and as Dr. Saroyan mentioned, successful with evaluated results and independent review by our partners in the federal government, determining that it's a strong program that's been happening since 2000, really launching around 2006 and going statewide by 2010 or 11. And we consider that absolutely important foundation for payment and delivery reform that is more broad and encompassing of a much larger range of provider types. So you mentioned One Care Accountable Care Organization. That is a network of provider types that is much larger than primary care provider types. And so providers across the state are participating in One Care Vermont as a network, and that network includes hospitals, it includes primary care providers, it includes home health providers, mental health and substance use disorder treatment providers, all participating in that model and working, again, as a network to deliver within an alternative payment model savings relative to a benchmark for healthcare spending. So if you think of it as One Care has a benchmark, all of the providers working within it are working together to try to do better than that benchmark. And when they do, then the savings are available to be flexibly invested across that system of care that's engaging and working together to improve, back to Dr. Levine's point, to improve health, to improve outcomes for Vermonters and to lower costs.
Thank you. That was helpful. And I wanted to go back to Dr. Saroyan, but before that, I just wanted, does anybody, Allison or Dr. Levine or Dr. Saroyan, do you have follow-ups for Ina? Are there points that you feel like you would like to talk about a little bit more? And if not, that's fine. I just want to give you the opportunity.
I would say even I am digesting what Ina is saying because it's such a big world. So I'm just going to validate that if I'm not alone.
Yeah. Okay, great. Okay. So thank you, Ina. That was helpful again. So Dr. Saroyan, I wanted to go back to the blueprint. You gave us a really good grounding in that when we started. With all of this discussion, I think it's really helpful, as Allison just named. This is just so big and it's so complex. For the blueprint for health, can you give us, and again, this is all uncertain. We don't know exactly what's going to happen, but how do you imagine healthcare reform? What are the differences for the practices out there? Can you give us some ideas about that? For healthcare,
Sure.
within the realm of healthcare reform?
Sure. I think that I know that practices are stretched. They're seeing more people with more complicated conditions, sometimes at one time or more unexpectedly than they ever have in their career. They're seeing people with what I call multiple different issues and problems in multiple different areas of their health, their family, their wellness, their security in their jobs and their homes. And they're very overwhelmed. They're very exhausted. and there's a spectrum of what's the term burnout's used, but there's a spectrum of experience over what the pandemic put on top of what they were already feeling. And the term healthcare reform can sometimes be met with a feeling of dread or fear or apprehension, that the promise that was maybe suggested this number of years ago, or something that they read or heard or were told or entered into an agreement with, hasn't delivered. So sometimes there's even a feeling of anger, resentment. And I think that what I value about the blueprint, Kathy, is that there are tangibles to it that I can easily identify with multiple reassurances as I've traveled the state and visited all of our administrative entities, all but one, to say that aspects of the blueprint, which are rooted in healthcare reform, like becoming a patient-centered medical home, still have value. They helped us recruit person X. They helped us interview person Y. Our community health teams in some areas of our state know that if a person's been in the emergency department that doesn't have a primary care physician, that there's a member of the community health team that follows up with them right away. There's members of our spokes team and the opioid hub and spokes treatment that know if someone's gotten seen in an emergency department, they can get them moving with treatment of their opioid use disorder within 24 to 48 hours very quickly. So there are aspects that come from legislation that come both at the state and the federal level that do create opportunities for recruitment, for better quality, for more timely care. And those are tangibles. The complexities of attribution, the financial modeling, those are quite daunting, and they take considerable study and evaluation and time to figure out which parts worked, which didn't work so well. But I hope I've named a few of the tangibles that Blueprint continues to develop. Deliver for clinicians and thereby families and individuals too. Most of what I hear as I talk to people is they want more. They want more community health team members. They want expanded capacity. They want to receive more for being and maintaining patient-centered medical home recognition. Those are some which is one in a leadership position isn't always able to deliver those things. On the other hand, in terms of a topic that for many is rather hard to digest and maybe even distasteful, it is positive, I guess, to hear that that there are some aspects of it that people want more of. And community health teams, the hub and spokes program, our patient-centered medical home, those are things that people, I hear over and over again. These parts are working. We wish we could do even more of it. There could be 2 of me. There could be 3 of me to meet the needs of the Vermonters in need of all sorts of different things. And I think that the community health team members that I've met have longevity, they have investment, and it's also fun to meet a lot of clinicians who've known about the blueprint since its pilot phases and are still enthusiastic about it. Those things are unusual in the topic of healthcare reform. Even for people who are dedicated and optimistic and leaning into it, it's in my experience, and people can certainly disagree, it's unusual to have like those things are working well. We like those things. We want more of them.
Oh, that's great. That's great. And I was going to go back to Ina about how healthcare reform, where you see it really directly affecting integration. But before we do that, I'm just realizing, I wonder, there's this term attribution. I wonder if you could quickly tell us what is that about? What do you mean by attribution, and why is it important?
It the term attribution is not necessarily important for this discussion. But I think we have been working in these models that change the way healthcare is paid for, and they change it based on attribution, meaning your payment for your reimbursement changes if a particular patient that has a particular payer is attributed to you, and then you have the responsibility for managing within that payment, for example, or managing the risk, for example, and delivering better outcomes, better performance on behalf of this population of people, excuse me, that are attributed. So the term accountable care, the accountability, you're accountable for those persons that are attributed. If a person is not attributed, then you're not financially accountable or accountable for outcomes. But I want to be very careful about that because, not every Vermonter is attributed to the Accountable Care Organization, for instance, and the providers who are participating in the Accountable Care Organization, just because not every Vermonter is attributed, doesn't mean that they aren't changing how they're delivering care for everyone that they see. And that's also been true with the Blueprint. With the Blueprint, there's also an attribution-based payment system for the performance-enhanced payments that primary care practices get. But as I referenced earlier, not all payers are participating in that. And so that means not all Vermonters are attributed for the purposes of payment, because maybe they have a plan like with a national health plan, like, I don't know, Blue Cross Blue Shield of Minnesota, or, and they're seeing a Vermont provider, but Blue Cross Blue Shield of Minnesota doesn't make payments for Vermont's Blueprint for Health program. But I think what we're trying to consider is whether that model, which is very technical and very convoluted, is necessarily the best model for thinking and moving more reimbursement on the whole away from fee-for-service reimbursement. So that's why I made that comment.
And then, like, for me, an individual on the ground going to get care, do I know or see anything about this attribution? Like, on a personal level, does that mean anything to me?
You may receive a piece of mail that indicates that you are attributed to the Accountable Care Organization, for example, and that you would have the option not to have your data shared. That is something that you would be aware of if you receive that piece of mail. When it comes to how the teams are transforming and delivering care differently, you may observe some of that, and you may not observe the way that those things are changing. From your perspective, you may always have had connections to a multidisciplinary team, and you continue to do so. I think it may not be something that you can readily observe.
Right. So essentially, it's really an administrative tool to group numbers of Vermonters with different different networks, so that you can be trying to influence how care is provided. Is that correct?
I think we say payment and delivery system reform, and we say that, and we talk about it together, because the payment is really meant to facilitate a change in the workflow for the delivery system. And that's why they are coupled together. So And I think that it is true that the delivery system may be very bound by some rigid rules and requirements that come or that are generated from fee-for-service system. And without that being more flexible, it may be very difficult to adjust workflows and to
Right.
adjust how you spend your time, for example, and whether or not as a practitioner you are able to spend your time perhaps coordinating with other practitioners, and that isn't then a loss of revenue, for
Yeah.
example, for your organization or your independent practice, for example. So I
Right.
don't think that I don't think it's only administrative in function. I think it really
Okay.
is that coupling of the payment change and the delivery system transformation. I think we can support, and there's a lot of work that supports delivery transformation that's not necessarily payment change as well. Like mentioned workforce at the outset of this meeting, and I think workforce development strategies very much can support delivery system transformation by introducing more workers into the pipeline, bringing more workers into training with multidisciplinary teams so that they are accustomed to working across what have historically been silos in the system of care, and they really approach care with a very different perhaps a very different uh, set of tools to promote better care. I say that though wanting to be cognizant of how collaborative providers in our state are, and how much providers and practitioners know one another, work in the same communities, have patients in common, and spend a huge amount of time working together as a community to deliver good care and outcomes for Vermonters. And I think with all of the payment and delivery reform talk, and we know that we always want to be at the leading edge and improving, but we shouldn't forget that our health outcomes in our state are very good, that we lead among states in having good health outcomes, that we have an older population and a population that's living in more in a significantly more rural settings, and being older and being in a rural state are usually associated with poor health outcomes. In the state of Vermont, we have both of those things in spades, rurality and older population, and yet we are still ranking in the top of states and the healthiest in the nation. So I don't want to, because we have ambition to continue to improve our system, and we know that there's work to be done, and we want to accomplish that, I don't want to come away with the idea that we are not doing very good things for the population already today.
Yeah. Okay. Thank you. So then if I haven't worn you right out, Ina, I want to go back to the question about healthcare reform, specifically around the issue of integration of care. And if there are any examples that you could give us about, individuals seeking care, how might it change the world for them, and equity and parity issues? Where is this in that realm?
Yeah, and we'll do this one in coffee talk style too, because we're here together in the room. I mentioned this continuum of payment change, and I do think that that's an opportunity within that continuum to use payment to incentivize providers to work together in an integrated fashion, and to do so in a way that also might alleviate potentially some workforce pressures. So imagine if a group of providers are equally and providers in what we would consider the traditional medical care setting and providers in a mental health care setting are equally accountable for a set of quality metrics or outcomes for patients. And any of those providers lead on accomplishing that process or delivering that service, and that happens, then the group of providers as a unit may be eligible for a shared interest payment, a payment incentive that is paid to the whole group of providers, but they don't all need to do the task. The task needs to happen once, and the providers are accountable to coordinate to make sure the task happens at all. So that's an example of a payment change that could facilitate a more integrated model of care delivery. And then I think we also have some, there in the blueprint, again, building on the spoke model, there's also potential other ways to promote more integrated care and service delivery that may be responsive to some of what providers in the field are saying, again, are the key issues that are more difficult to navigate, especially in our current state.
And Dr. Saroyan, did you have something you wanted to add there, or?
Like an example, Kathy?
Yeah, I did, since Ina was talking about the coffee, morning coffee, model.
Sure. I'll just give a little background, and then I know we went right through our break and we're into the team's working time too. So I'll try not to be too long-winded. Is that true, or am I wrong?
No, I'm sorry. We've got until 10:30. We can go until I have a feeling I sent you an old agenda. That's my fault.
Okay.
Okay. Confusion. I'm sorry. And we can do this. We'll see how this, and we can break earlier if that happens.
No, I'm happy to answer the question. Sure. My thinking around the whole person and the integrated care language really comes from my own experience as a quote unquote patient person, someone being treated in healthcare settings. It comes from my interactions with thousands of families, maybe more, that some of whom are very much wanting to get connected with a provider who may be labeled under the rubric of mental health, and many others who the whiff or the scent of anything labeled under the rubric of mental health, they've stopped listening to me. So the ability to help individuals, whatever their needs are, with a teammate who is quote unquote down the hall or available immediately through some other connection, is a very powerful relationship, trust building mechanism to maximize a family or an individual's chances of saying just a few more things about what's on their mind, or why they think their house is unsafe, or why they feel threatened by someone in their close circle. Without that team-based care, the ability to go down those threads that perhaps weren't listed in the chief complaint when the person called or sent a message as to why they're going to come in can be close to impossible without disrupting an entire afternoon, morning, day. And not to say that the disruption's not worthwhile. It's very worthwhile, but there's other people waiting. And to have some degree of expertise on one's team to keep the conversation going, to do a little bit more of an assessment, to see what the immediacy is. For me, whether it be labeled in the mental, the physical, or some other domain, maybe it's spiritual or existential, that is integrated care, that is whole person care. It's very difficult to convince payers that that's worthwhile. It's very difficult to year over year over year over year keep investing and proving that that's return on investment, particularly to a clinician who believes in it, was trained in it, and maybe it was called something else when I was in medical school. I can remember the term it was used, but it's kind of the same thing as what it was labeled when I was in medical school, whole person. I mean, the older labels don't matter. So that's where I see Blueprint for Health in conjunction with Ina's leadership as Director of Healthcare Reform, giving us here in this small state a chance at really being who we want to be, being who we imagined we would become when we decided we wanted to be providers in healthcare. So that's how I see them being linked together, both from the more granular to the more elaborate payment models.
Excuse me, that's really interesting point, Dr. Soroyan, and it makes me think back to Allison's comment about the medical model concerns. And I wonder, maybe from your perspective, Dr. Soroyan, can you, you touched very much upon it, but I'm wondering, really thinking about that term, medical model, that we all use, can you reflect on that in terms of this integration and what you just named with the community health teams and with healthcare reform, how you see healthcare reform infecting that was quite the slip, affecting this issue around medical model and mental health care? What do you think about that?
Sure. I'll do my best. I was trained as a pediatrician. My first mentor when I was in high school in the 1980s probably would have really shrieked if I tried to divide up one of the children or families that we were taking care of with critical illness into different components. He was a leader nationally and internationally in teams-based care, and many of the principles that came out of pediatric oncology led to palliative care, led to some of this language, even with consultants that we talk with now around whole person care. So for me as an individual, even back into my medical school training, I was probably on the outside of the thinking that people are in the question you're asking. Perhaps you're reflecting the concerns of people saying that I'm going to be medicalized, I'm going to be chief complaint, diagnosed, labeled, prescription, out the door, goodbye. So I think that's that's not the way I've ever wanted to practice medicine. It's not the way I've ever wanted to train people. Of course, there are many episodes in one's life as a trainee and a clinician where that model saves lives over and over and over again in emergencies, in situations that are life-threatening, where that model has to be employed to do one's duty to the patient. There's many other aspects of life, living and wholeness and happiness and joy in one's life where that model can alienate people or not be based in building trust. It can make people feel pathologized or like they're broken. And I think that as a clinician and now as a clinician who's in a leadership position, I want both to be available so that the patient and the family can participate in the determination of how they want to be treated. But it's very difficult and complex to give an answer that's somehow going to shape every single clinician's or practice's ability to do that whilst they are working in a system and they were trained in a way that while it allows for electives and other pursuits, they have to meet the standard of care of their licensure. There are naturopaths who are providers who participate in the blueprint. There's a naturopath on our executive committee. I certainly pride myself in learning more and learning as much as I can to not just talk about this model, but find ways to deliver and support it as an executive director. I hope I haven't talked around the issue too much, Kathy. It's a big question about which I feel very strongly. So I'm happy to clarify anything I said or say more.
No, thank you. And you know, by the same token, I don't mean to put someone on the spot. To me, this is again another example of there's not a hard and fast 3-word answer. These are, as you just named, Dr. Shroy, is very complex. And there are times when what we call the medical model is exactly appropriate. And so I think naming these concerns and talking about them, it's really a central task of this council to keep bringing out these points and getting them so that we're talking about them, defining our terms, so that we can be as clear as possible in the midst of all this uncertainty and change. So I thought that was helpful. I wanted to, Ina, can we talk about the issue of parity? And by that, I'm talking about reimbursement for mental health services and medical health services, the parity issue of payment there, and issues of equity, where you see healthcare reform addressing these two huge topics.
Well, I saw my colleague Sebastian on the meeting a moment at some point. He may or may not still be here. I can't quite see all of the participants, but I think
I'm still here.
The department. Oh, great. So I don't want to speak on behalf of Sebastian, but I do know that the Department of Financial Regulation, in its consumer protection role relative to commercial insurance coverage, is doing a lot of work that certainly promotes parity consistent with what is required in terms of commercial coverage for mental health and substance use disorder services specifically. So I don't know if Sebastian wants to talk a little bit about that, but I think that that's really my work is to coordinate those efforts. And we have expertise in the DFR and the Green Mountain Care Board and the Agency of Human Services, and I want to lift up those expertise in those other departments.
Yeah, so just really quickly to go through our efforts on the mental health front. So in Title 8, which is our insurance, all of our insurance laws, we have a mental health parity statute that says that health insurers can't impose any rate, term, or condition on the coverage of mental health services that's not imposed for physical health services. And we interpret this quite broadly. So one of the projects that we're working on in this regard is we're working with Dana Robson at the Department of Mental Health on a working group to identify and remedy barriers to access for residential mental health services for children. We also worked with the commissioner of the department, Commissioner Hawes, to identify prior authorization requirements for inpatient mental health treatment. And after we met with the insurers, Blue Cross Blue Shield of Vermont, which was the only insurer that had such requirements for inpatient mental health services, agreed to drop those requirements. And I think that will be effective either soon or at the very least by beginning of 2023. And then I think lastly, we have a federal grant, and one of the things that we're going to try and do with our grant is engage a outside contractor to help help standardize our insurance form review processes, to be able to catch things like that prior authorization requirement, or different requirements for, say, antidepressants in an insurer's formulary. That way, we can address those things at the form filing stage instead of waiting for a consumer complaint to come in.
Thank you very much, Sebastian. Thank you for jumping in. So can we talk a bit, Ina, about the equity? Do you see healthcare reform directly addressing equity issues in any way, or how do you see it? Yeah.
I talked previously, as well as Dr. Levine mentioned, that we work with federal partners in what's called the Innovation Center, and it is called the Center for Medicare and Medicaid Innovation. It was created by the Affordable Care Act. It was created by the Affordable Care Act specifically to test new payment and delivery models in Medicare, and without Medicare needing an act of Congress in order to pay differently than fee for service. Medicare is very, original Medicare is very steeped in and works in the confines of a rigid fee for service reimbursement model. The Center for Medicare and Medicaid Innovation has prioritized, where it can, all payer innovation projects, again, for that, with that rationale that with all payers aligned in providing, for example, a more flexible payment, and all payers aligned with, in terms of what's important to deliver for quality and outcomes and value. If all payers are contracting with healthcare providers in a similar way, then the signal, the incentive, the flexibility will be much more accommodating to achieve that outcome. The Center for Medicare and Medicaid Innovation has recently issued what's called a strategy refresh. They've been around for, 10 plus years and really kind of operating at a pretty good clip for the last decade in terms of testing and promoting new payment and delivery models. But in their strategy refresh, they really put a different emphasis on health equity for their models, as well as emphasizing how models can help to address health-related social needs, and that equity and addressing health-related social needs should be at the center of innovative payment and delivery models. And again, I think there are some ways that we have already identified about more flexible payment and delivery models that can better promote health equity, because it allows for providers in the system of care to have flexibility in meeting needs for all patients, and even for focusing on where there are health disparities as well. So I think we will continue to work with that central to our exploration of moving forward with continuing payment reform in the state of Vermont. And we're also looking to the expertise at the Innovation Center, as well as they've reframed their thinking around health equity. But I think that it is also a work in progress for them, as it is for us. But maintaining it as central is what we will be doing.
Great. Thank you. Well, we're getting close to wrapping up. Before I go back to Allison and Dr. Levine, Ina, I'm wondering if you can give us some suggestions for our, we have these 4 work groups, one focused on primary care, one on pediatric care, one on funding and alignment of performance measures, and then the workforce development work group. What could we keep in mind about healthcare reform as we go forward with those work groups on this council? Are there ways that you think that it could inform our work specifically?
Well, I mentioned that concept of a shared interest payment for a group of providers. And that shared interest payment could potentially be bridging providers that are not necessarily working under the same payment model, but could link providers that are in different payment models. So for example, there could be a link between providers working in a particular hospital payment model, like a global payment model for hospitals, and providers working in the designated agency system, for example, that are not a part of necessarily that hospital's global budget and payment. And when I think about that linkage, the linkage point would be, again, relative to the triple aim. Why are we linking, and what is the better health and the better care that we're looking to deliver? And that seems like a place that is ripe for discussion in the quality metrics work group, for example. Where can we identify some co-priorities and outcomes that we would potentially want to be unified in accomplishing across and between provider types and systems? That's one example. I don't know if Dr. Saroyan has some ideas about the primary care and the pediatric spaces.
Sure. Thanks, Ina. I would be curious to know from the work groups, Kathy, if members have any experience with community health teams, if they have experience with aspects of Blueprint programs through their lives or through their professional work, and what they would like to see more of, if anything. That would be helpful to me, and the leaders of the group could certainly just contact me directly with what they're hearing, and that would be very helpful.
Oh, that's interesting. Okay. And the facilitators also, if it's however it's easiest, if you want to funnel things through me, or if you just want to send them to Dr. Saroyan,
Yeah.
It doesn't matter however it's easy. That's great. Okay. Well, as we start to wrap up,
Do you want to say something?
I wanted to, I'm sorry, was there anything else? From either.
I only wanted to speaking to the workforce group, which I know Allison is involved with and mentioned, I think there are also lots of opportunities there, considering like flexibility again and multidisciplinary teams, and how teams are supported to work at the top of their licenses, and to have members of their team that are appropriately providing care and services consistent with their training and ability.
Great. Okay. Thank you. I didn't mean to cut you off. Were there other points that, no? Okay, great. So I wanted to ask Dr. Levine and Allison as we're wrapping up, and thank you everyone, that this has been a long, in-depth discussion. I'm sure everyone's feeling tired. We're going to take a break next. Before we do that, Dr. Levine, Allison, as you're reflecting on this conversation today, are there a couple of critical points that that you're going to keep in mind? Are there takeaways that really got your attention? Dr. Levine, do you want to go first?
No, but I will.
I was going to say, you could say no.
You know, I hate to reduce it to this, but I think one of the take-home points is it's really complicated.
Yeah.
And if people came into the meeting thinking it's really complicated, I'm not sure that they're going to leave the meeting thinking it's less complicated. That's not a failure of the presentations. That's where we are as a country and as a state. So can I say? But
Yeah.
But one thing I'm kind of hearing, but I think everyone would appreciate a little more of. We've covered many models, and these models are integrated models, needless to say. Some of them are kind of sponsored by the federal government, like the CCBHC. So if I were to be bold and say these things can be paid for, well, certainly that model can be paid for because we've had a number of our sites receive grants to accomplish that. And they're part of a federal scheme, if you will. But then there are other things that we haven't really focused on as much today. But, you know, we use the word whole health, you know, liberally.
Yeah.
But that, of course, embodies a number of models that we've seen that other places have pulled off. So I'm going to leave with the impression that Vermont can pull it off as well. But we haven't really spent as much time being very specific to Vermont's kind of own special mix of waivers and innovation deals and what have you, as to how multiple different models that we've discussed would actually become feasible if we as a council were to sort of recommend them at the final hour, so to speak, of our existence. But I'm going to come away thinking that there is a lot of innovation that is feasible, and anything we do as a council is going to have to be highly informed by those who understand healthcare reform. And we wouldn't want to be making recommendations that don't really pass the litmus test for this is actually something you could pull off. But I'm feeling optimistic about that, not pessimistic.
Thank you. That's great. Thank you very much. Allison, what do you think?
I too am optimistic and overwhelmed. I think one thing that I got out of listening to Ina and Dr. Sorian talk is that there has been so much work done already, that this isn't some brand new concept and we're just getting started. Like, we've been at this a long time. There's been a larger vision. There's just a lot of pieces to put together as we work towards it. And I think two things come to mind for me. One is it goes back to the piece about medical model, because I think now that I've had some time to think through that question you asked Kathy, and then a credit to Ward Nile, he sent me an email with some other thoughts that really started making me think about what that actually means. When people who have been stigmatized in the past go to get their care at places that they've known to be more diagnostic based, there's a concern about what that's going to look like for them. And will it be, what's your symptom? I've got this medication. And so it's twofold. I think it's about learning about what the community health teams do and how there's more of this like personal outreach and thoughtfulness about what somebody's goals are and how do we work together. How can we make sure if more mental health is being done in those spaces that they're thinking about it in a really trauma-informed way, and they're seeing alternatives to medication as a potential path for folks. And we've seen that in population health, right? We're not trying to go straight to blood pressure medication. We're trying to go to other, actions and healthy lifestyles first. So that's something I think we need to talk more about, and just making sure that we're all moving in that direction on both sides, whether you walk in the door at a mental health agency or healthcare agency. And the second piece for me is I've seen it in our move from fee for service to more value based care. It's like so exciting and everybody loves the change, and yet providers are caught in the middle because we can never really quite cross over the line, and there's still this sort of straddling. Like some things are still in fee for service, some things are still in a case rate. The example of FQHCs and CCBHCs, Mary Kate Molman pointed out the other day, one's SAMHSA and one's HRSA. So like even that has two sets of parents who need to be talking, and you filter that down to our middle management of that and trying to get it out the door, and you've got agencies and organizations twisting themselves in knots trying to pull down funding wherever they can. And so to me, it just reiterates the need for groups like these to come together and say, okay, what's your list of what's you're accountable to? What's your list? What types of providers are necessary to get there? And then making sure we're giving the people served that chance to shout from their rooftops, hey, like, I'm still not getting what I need. And so then we tweak it.
Yeah.
And so again, it just, that's the way that it comes to mind as I'm thinking of this push and pull. And the speed by which state government goes. I like to move fast. I love change. You can barely rewrite a manual by the time the rules have changed, and that leaves people pretty confused about how to do the work as well. So like there is a pacing to this that I think we need to be somewhat realistic about, that people can keep up with.
Yeah. Great. Thank you for that. I just wanted to back up. You used SAMHSA and HRSA. For those not fluent in these acronyms, they're both federal agencies. SAMHSA is the Substance Abuse Mental Health Services Administration. HRSA is the Health Research, and Ina, help me here, Health Research Services Administration, or what's HRSA? Or maybe Susan Barrett can jump in.
Health rural is the R for.
No, it's, this is Mary Kate. It's Health Resources and Services Administration.
There we go. There we go. Thank you, Mary Kate.
Oh.
So two different federal arms. SAMHSA oversees the Certified Community Behavioral Health Clinic model, and HRSA oversees the federally qualified healthcare centers, which we heard about in January. Thank you so much. I've been involved with healthcare reform very much on the periphery, but I've been around it for at least a decade. And I learned so much today. It's just really helpful. You all and really stuck in there. This has been long, and thank you to everyone, all the participants who've stuck with us. We are going to take a 15-minute break now. You should all have in your email a link, and we're going right to our work groups.